environmental cleaning, testing and isolation. And as we look at each situation, we use combinations of these prevention tools to address it. So in a workplace, we make sure we do symptom screening in the morning before people can even arrive at work. We make sure that they put on their cloth masks and maintain social distancing in the travel that they do to work. So in each setting, we can draw on the combinations of these tools so that we can address each of these challenges. But let's look at one of the challenges that we've been grappling with and one of the tools that has seemed to be used to a great extent, and that's the lockdown. Because when this initial infection occurred, we were not able to follow our traditional public health paradigm. Our public health paradigm is we understand the way the virus spreads, we develop the ways in which we can slow it down or stop it, and then we develop our messaging, we pilot test it, we then introduce it to our early adopters, and then we wait for diffusion. If we did all of that, we would just miss the boat on this virus. And so we had to act quickly. Well, how has our world changed in the last 4 months? In the blue are countries that have no restrictions. In the yellow are countries that have some optional restrictions. And in the orange, we have countries that have substantial stay-at-home restrictions, including the dark orange, where we have strict lockdowns. On the 1st of March, this is what our world looked like. On the 1st of April, changed completely. 86 countries on national or sub-national lockdowns. Look at the situation a month later on the 1st of May. And then on the 1st of June, you now see China is back to being on a strict lockdown. Australia and New Zealand have no restrictions. Africa is easing restrictions. South America still has restrictions. You go to the 1st of July and see how our country is changing even more. Our country has our countries and our world has changed so dramatically over the last 4 months. So what has the impact of these lockdowns been? I've chosen to compare South Africa to some countries that have the most substantial epidemics and some countries that have quite much less severe epidemics, South Korea and Australia. And if you look at South Africa, what becomes clear is the way in which the epidemic has grown somewhat differently. And that difference is evident when we look at the way in which the lockdown changed the transmission of the virus. So in the 3 weeks that we had this epidemic from our first case, our doubling time was every 2 days. From the institution of the lockdown and the state of disaster a few days earlier, on the 26th of March, we slowed the viral transmission rate down to a doubling time of 15 days. And currently, as we are easing the lockdown restriction, we are now doubling at 12 days. Giving you some idea of the way in which we were able to flatten that curve initially. But the virus is now spreading at a rapid rate. Easing restrictions is just the way in which this virus is now able to spread. And we are seeing within South Africa several super spreading events. And indeed, some of the early transmission occurred in grocery stores and supermarkets, which were open under the strict lockdown. Let me end off on one of the challenges we are all going through. We instituted an initial intervention of state using the institutional power of the state to ask people to please stay at home. That created anxiety. People watched on television. In South Africa, they watched how the situation was unfolding in Italy, how it was unfolding in New York. And they began to see the challenges and the deaths that they were being caused. And so we used that authority, we used that capability initially. And anxiety was created, concern was created. But now we are asking people to live with this virus, to find a way that they can coexist because livelihoods are as important. And so we're asking people to take agency, to create their own power, their own willingness to take action. And that action is through a mask, through social distancing, and all of the other things. And as we do that, we are hoping to achieve collective action, because it's through our collective action that we make a difference. That when we wear a mask, we are saying to the world, not only are we caring for ourselves, we are caring for you. Our risk, each person's risk, means that we're putting our families at risk, we're putting our neighbors at risk, we're putting our communities at risk. And so in some communities, for example, in South Africa, we are built on the principle of Ubuntu, which is I am because you are. And as we reflect on that, I'd like to just conclude by saying that effective prevention is built on our ability to address all three modes of transmission. Our prevention toolbox is quite well stacked, but it really needs a vaccine. We desperately wish every success to all of those candidates currently in development and in testing. And we need to continue learning. We need to understand more about this virus each day. Lockdowns, we've seen, can slow viral transmission and even achieve temporary containment, but they are really not sustainable over long periods. We have so much to learn about how to use these tools in different ways from our toolbox. As we shift from restrictions to living with the virus, we're going to need to pivot our prevention paradigm away from anxiety, away from concern, to believing we can make a difference. Each one of us can contribute not only to protecting ourselves, but our entire societies. And those societies that embrace community, embrace individual interdependence, are best placed to successfully pivot under the concept in South Africa, which we call Ubuntu. Thank you.
I'd like to thank Professor Karim, and please stay with us because we're going to have a discussion after the final talk. I'd now like to introduce Ambassador Deborah Birx, who's going to present on COVID-19, aligning data and implementation for action. Ambassador Deborah Birx currently serves in the Office of the Vice President as the White House Coronavirus Response Coordinator to aid in the whole of US government response to COVID-19. As an ambassador at large, Dr. Birx is also the coordinator of the United States government activities to combat HIV and AIDS and US Special Representative for Global Health Diplomacy. She's a world-renowned medical expert and leader in the field of HIV and AIDS, and a 3-decade-long career has focused on HIV, immunology, vaccine research, and global health. As the Global AIDS Coordinator, Ambassador Birx oversees the implementation of the United States President's Emergency Plan for AIDS Relief, also known as PEPFAR.
Thank you, Dr. Pozniak, and it's so good to be with all of you today. And what a great lead-in, talking about the data and the aspects of the virus and ending with community, which I think is really the lesson learned that brings together the COVID-19 response and our HIV/AIDS response. And I want to thank the two prior speakers for framing this so well. I'm going to go quickly through a set of slides that really highlights how we're approaching data in the United States. But just to remind people, the primary cases to date have really been in high and upper middle income countries. And primarily the mortality has been in high income and increasing in upper middle income countries. This is a little bit different than we thought a respiratory pandemic would look like globally, as we thought that resource limited settings would be particularly hard hit. But because of their differences in comorbidities and their incredible young, youthful populations, they may have less mortality than many of the other countries in the high income and upper middle income strata. Just to remind people where we are overall, where the United States sits relevant to Brazil and Russia and now India. And India, I'm sure at this moment has surpassed, really pointing out where this is actively spreading. In the United States, we have increased number of cases over the last particularly 3 weeks. We have not seen this result in increased mortality, but that is expected as the disease continues to spread in some of our large metro areas where comorbidities exist. So how do we look at this? Well, every state in the United States is different. And so this slide clearly illustrates that difference. You see right now that the epidemic is growing in the blue line, California, the green line, Texas, and the darker line, reddish line, Florida. But you can see that it spread earlier in New Jersey, as shown on this slide. But now they have reached a very low level of case increases, and the primary increases now have moved to California, Florida, Texas, and Arizona. We look at this through all of the states, and you can see here Oregon and others increasing. And so that we look at it across all states and our District of Columbia. And then we also look at this graphically so we can see rate of change. And so this really looks at percentage of change over just the last 7 days. And you can see the primary red areas across the southern United States, which was spared originally the first March, April cases that were very much more in the Northeast, Detroit, and Chicago. Over the last 4 months, we've worked hard to expand testing, and that has allowed us to look very carefully at this issue of changes in percent positivity. It is that change in percent positivity shown by the red X's over the little blue triangle that alerts us that there's active and ongoing community spread. And you can see that very evident in Texas, Florida, California, South Carolina. And so this allows us to really focus our resources on expanding testing and community level testing to really deal with the asymptomatic group that we know is spreading the virus and may be linked specifically with age, with increasing asymptomatic spread in the younger age groups. We then look at percent positivity over time. And again, this illustrates very well the change in increase in percent positivity that occurred in very early June in these states of Texas, Arizona, and Florida, and really illustrates how this percent positivity of tests when you're doing large testing can really help us. You can see California now has reached over 10%, which is our cut line for really significant community spread. And then you can see other states have a very low seropositivity, pushing mostly 5% in a stable way. And that's the rest of the United States at the current situation. Again, we look at percent positivity across the country and changes in percent positivity and the new positive results generated by our assays. And then the percent positives. And this really, the dark colors illustrate the percent positives that are over 10%. And again, United States is a state by state, county by county, and that's the way we've made our response, very much looking at a very granular level and then working with the governors and the mayors to have a very specific and tailored response for each of these areas. To give you an illustration of what this looks like in our daily reporting, this is what goes to multiple individuals on the task force in a daily way. The real key to this is the positivity rate and the incidence. So looking at this blue line, which is the percent positives, which in Florida as a whole is at about 15%. And then looking at the cases, this is also looking at syndromic presentations, which is a little bit later than the increase in percent positives. And this is related to people coming to the emergency room or to clinics. Just to give you an idea, then we look down at the county level so that within the state, we can identify the counties that have the most rapid increase. And you can see in the case of Florida, it's Miami-Dade, followed by Broward and Palm Beach. But you can also see this recent increase in Hillsborough and Orange County. And again, this allows us to work directly with the county health authorities. And more importantly, as brought up by Dr. Karim, getting in and working directly with the communities so that we're communicating with the communities. This is what Texas looks like, and I'm just going to highlight some of our states with this expanding epidemic. And you can see for a very long time, Texas was very low at about 5% positivity rate, had a very small increase back in the March, April timeframe, and then this very significant increase in test positivity and rising cases. The test positivity preceded the significant increase in cases that were documented. And this is by county, showing that the primary county with expanding cases is Harris County. This is our Houston area, followed by Dallas, but there's a whole series of counties that are on a highlighted concern. And then this is California, which again had a very early shutdown, dropping test positivity, and then a very recent rise in test positivity. And again, in California, most of the cases are in the Los Angeles County area. And this is Arizona, which had a parallel increase in the test positivity earlier. So you can see much earlier than Texas or California or Florida. But again, this delay in increasing ER presentations. We think this really represents our ability finally to pick up asymptomatic cases with that rising percent positivity. And I really want to thank our young people who have been coming out and getting tested even though they don't have symptoms. And in Arizona, the primary expansion is in Maricopa County, which is the Phoenix area. And then this is Wisconsin. So this can happen in a very subtle way. So you can see things are looking good. They're coming out of the lockdown. They have very low positivity rate of about 2 to 3%. And then you see this slow uptake of positivity and then expansion of new cases. And in Wisconsin, it's primarily the Milwaukee area. And so we look down at the metro areas, just because the metro responses, what's happening in the cities is sometimes different than what's happening in the state as a whole, because we have very rural counties in states. In fact, we still have states today with counties that have either no infections or have only had one infection since the beginning of the pandemic in the United States. And so this data is then triangulated, looking carefully at slope lines so that we can determine rate of increase, then looking carefully at rate of increase of test positivity. And you can see in this slide of Houston and Phoenix that are over 20%. And then you see Dallas and Tampa and the rising test positivity in Miami. And then these are the other metros, which are more stable with less than 10% positivity and that are very stable metros. So this is done every day so that we can understand what's happening across the country. This is obviously also mirrored in the individual state levels. This is what we look at the metro level. So this is looking at Miami. So again, you can see when this increased test positivity started, it predated a significant increase in the cases. All of these alert bars are created. So at a glance, you can flip through all of the metros in the United States with more than 500,000 inhabitants and really have a sense of where the virus is increasing or decreasing. This is Houston, similar, and this is Los Angeles and Phoenix and Milwaukee. So I think this gets back to what Dr. Karim talked about and Dr. Fauci talked about is the skewed demographics coming out of a report of the CDC's MMWR, and the skewed demographics of significant increased disease among our Hispanic population, followed by our African American population. Of course, our Native American population has the highest attack rate. And we map this then against resources. And you can see the primary outbreaks are around both outpatient and inpatient, primarily the inpatient. This red line are in individuals that have a household income of less than $25,000 a year. And so this is like HIV in that there are specific vulnerable groups, either by race, ethnicity, or their relationship in poverty. And so this is really allow the HIV type approach of really reaching people in the most vulnerable situations with increased testing and access to healthcare and really tailoring messages directly to those communities. We know from the work in Italy and as presented by Dr. Fauci, certainly hypertension and diabetes are a critical comorbidity. If you look where those comorbidities exist in the United States, it's very much in the mid-Atlantic and across our southern states. If you look at where our diabetes is and our increased diabetes, it's very much in the Midwest and across our southern states. And then of course, if you look at obesity, again, mirrored in across our southern states. So really increasing the messages to communities and critically getting testing to the communities. And I think this is something that has been done so extraordinarily well in HIV, where you have to find the asymptomatic individuals to stop community spread. Same principle in this respiratory disease. And I think early on that was hard for people to understand, that we're used to having alerts related to actual illness rather than infection. And so bringing the skills of community work. So just to conclude, This is what our daily data summary looks like. I wanted you to all see how it translates down to a single slide with the data behind it that shows where the increasing cases are, both by state and by metro. Right now, currently 4 states account for more than 50% of all new cases, and unfortunately increases in mortality. Currently, we have 8 states that have over 1,000 cases a day. And then we really believe that the uniform use of masks in all metros and in all areas with rising new infections, particularly counties and metros with over 5% positivity. We know, as Dr. Slim Karim presented, there's a lot of indoor transmission. So we think when you have rising infections, closing those bars, limiting indoor dining, and particularly increasing outdoor dining. Not sure that we have the full information from the protests yet, because we are starting to see early rises in cases in some of our metro areas, and we need to track that very carefully. We then note which states have increased cases or rising test positivity. Right now we have 28 in addition to the 13 and 10 stable states. We have 154 counties that are on alert. The United States has over 3,000. So this allows us, again, to constantly be looking at where the virus is by state, by county, by metro. And that only reason to have data is if it leads to very definitive action. And it's this kind of tailored approach, working with governors and mayors, that allows us to specifically go to individual states. I love the way Dr. Karim talked about cultures and different cultures. The United States has significant different cultures and approaches to health across the United States, with individual independence in some states greater than others. And so really going and sending deployment teams directly to what we call the hot states, as well as the states that are between 5 and 10%, which we call the yellow states, and alert, to really work with down at the community level and meet with the community level, as well as the state and local health officials. We have a weekly call with all the governors, and now have a comprehensive data sheets that go to them along with recommendations. And I just want to leave you with a concept of, we really need to increase our footprint indirectly into the communities. As described, these are events that are happening sometimes in households, sometimes in multi-generational households, sometimes a party, leading to significant spread. So making sure that we're getting information to the household, and then expanding our testing to what we call household pooled testing, which allows you to test an entire household with a single test, and then go back to the households that are positive and isolate those individuals either in that household or in a hotel, where multi-generational households, understanding that our risk reduction really needs to focus on improving the outcomes for the most vulnerable, identifying them, and then working together, as Dr. Karim described, as a community of Americans, really protecting one another through our own agency. I love the way he put that, where each of us can contribute to the health of the nation by wearing masks, reducing our indoor interactions, decreasing our gatherings in indoor settings, and moving a lot of our activities to outside. Obviously, we're working very hard to get remdesivir distributed in a very equitable way that goes out by the number of hospitalizations, and then the work that we're doing to get plasma available. So I want to just thank you for the opportunity to talk about how we're approaching this. And Dr. Fauci is a daily colleague of mine to make sure that we're responding comprehensively to this virus as it circulates in the United States, so we can prevent further community spread. Thank you.
Thank you very much, Ambassador Birks. And now we're going to move to the discussion part, and I'm going to ask my colleague, Dr. Beira, to start with the first question.
Well, thanks very much, Anton, and thanks to all 3 of the speakers. Let me just begin by thanking you all for your extraordinary service to this COVID response. You all have been just remarkable leaders. I'd like to take the first question to Dr. Fauci And Dr. Fauci, you ended with vaccines, which we're all, of course, very much hoping are going to be the most potent tool in the COVID toolkit soon. I wonder if you could just speak about the strategic thinking of going into trials with multiple platforms. So the nucleic acid platform, the viral vector, and the protein subunits, among others. And just articulate for us the thinking behind that strategy.
Well, it was a combination of things, Chris. We wanted to get out quickly, and some of the earlier ones, the mRNA, were ones that we were able to get off the ground very quickly. There was experience with other diseases with the vector. And then there's the tried and true protein, which was the kind of thing that was behind temporally, but nonetheless, not any less important. So what was done, at least at the level of the federal government, because there are so many others that are going about this independently, but the investment that was made by the United States government was try to subsidize the development of the product itself, but also to make available our clinical trial sites, which, as you well know, which we built up over decades with HIV/AIDS, to utilize those and make them available as sites to the different companies. So it was really one of those concepts, Chris, if you are a hockey person, that multiple shots on goal, some that you can get off quickly and ramp up quickly, some that have more experience, and some that we know are tried and true. So all of these things are going on. As I've said publicly, and I believe it's true, that if we're going to get a vaccine, which I am cautiously optimistic that we will get a safe and effective vaccine, that there will be multiple candidates using multiple platforms. I think we're going to need that, Chris, because we have a responsibility to the entire planet, not just to the individual country that's making the vaccine. So we're very well aware of that. And the reason why the companies that we're dealing with are already in discussion to start gearing up to make hundreds of millions of doses. And a couple of the companies are promising that they would have 1 billion doses within a year or so after it becomes. So multiple shots on goal, hopefully more than one success.
Ubuntu for the world.
Right.
That is really Ubuntu.
Exactly. Thank you.
Dr. Karim, we heard quite a lot from Ambassador Birx about risk factors. And, you know, around the world, there are a lot of extended families, multi-generational families living in poor housing with very low income. And South Africa is not an exception to that. Can you outline some of the lessons that were learned from the severe lockdown as applied to that sort of community and how they responded?
It was quite striking, Dr. Posniak, the way in which people initially responded. There was a lot of support for the early action because there was some initial concern about what is this virus. But as we continued under the first initial strict lockdown, it became clear that there were certain challenges. One of those was the use of the military to try and ensure that people were safe. And there were some abuses which were very unfortunate and really deeply regretted. But as we've seen now, we've had several consequences of our early lockdown, one of which is the challenge that people had in going to healthcare services for their usual medications and so on. But perhaps one of the things that most impacted on what we were doing was that there was a lot of anxiety and fear that if they went anywhere, if you went to the hospital, you went to the shop, you would acquire infection. So we had to overcome that through education, through engagement. And it's not just about telling people. It's about working with people to understand where their real concerns are and to overcome that, and then to enable them to move to the next stage as we ease the lockdown. And now we're in this very awkward situation where we're easing the lockdown. We're now in week 15 of our lockdown. We at a very low level of what call it a very light lockdown right now. We sort of more or less minimal lockdown. But while we're in that situation, we have an increasing number of cases. I call this period, it's a sort of damned if you do and damned if you don't, because no matter what you do, you're in that contradiction of the cases going up, but you're easing your restrictions because you want those restrictions to be replaced by individual action. You want to be replaced by community action. And making that transition is the challenge that I refer to.
And have you, just to follow up on that, have you seen community groups being formed and being as active as we've seen in the HIV arena?
Very much so. Initially, I think people didn't really know what this was about. But it took a matter of 6 weeks, 8 weeks into the epidemic, and we began to see the community activity and the community action. The churches played a big role in it, even though churches themselves gatherings were prohibited. And now, one of the ways that's become very obvious is that the government had a group of scientists that I lead, 51 scientists, mathematical modelers, clinicians, public health specialists, laboratory virologists, and we were the predominant advisors to the government. The government has now created a second ministerial advisory committee. It was initiated about 2 weeks ago, which is really about community groups and 30 different individuals that represent a range of different sectors of community action have come together to really give the government that bolstering capability to now change from what we were doing, which is a public health focused response, to one that's now a community-based response. And that's really something we learned from HIV. We're just using many of the techniques that we learned and developed under HIV to more effective capability for COVID-19. It's not without its challenges. I don't want to make it sound romantic, but that's what we have to bank on in the absence of institutional control. Individuals got to assume that control.
Ambassador Birx.
Thank you. Ambassador Birx, I was just going to ask about the, sorry, Chris, about the same happening in the United States in terms of engagement of community.
That has been really a very important question. It's why I was on the road for the last week out in Arizona, New Mexico, Texas, and then Florida to really work with not only the state and local health officials, but with community groups to really bring their voice and action to the table and making sure that they understood the importance of testing, household testing, and knowing your status. So really bringing together, it's very difficult when you think of the individuals under 30 and you think that potentially up to 80% of them could either be asymptomatic or mild disease, and asking them to come forward and be tested and self-isolate and ensure they're wearing masks and they're protecting their multi-generational households. This is a lot to ask of young people. And so really ensuring that we're reaching, just like we had to in the AIDS community, when we want to prevent illness and we want to prevent disease, we have to go to the young generational leaders and make sure that they're a voice in the community with their peers. And that's been, I think, because it was a respiratory disease, that is not a usual approach for flu. So really bringing that kind of HIV community voice and viewpoint to the response, I think, is really quite critical.
I think we have time for one last short question, maybe. Dr. Fauci, back to you. Ambassador Birx raised this issue of pooled testing strategies as an important component of the next phase of the response. I wonder if you could talk to that as a public health approach to COVID control.
Well, it could be a very important component, Chris. It really is going to depend upon how much penetrance of infection is in the community, because in certain times, if you have so much, it doesn't work. That's the point. So what you really need is to get a good idea in general of where you are and then apply that. There are different models that Deb and I, mostly Deb, are working on about trying to figure out what is the best statistical approach towards the relationship between what's in the community and the benefit of doing pool 5, pool 10, pool more. It's complicated, but it does play a role, and I'm sure is going to have an important impact on what we do, because as Dr. Birx, Ambassador Birx has mentioned, the situation that we're facing in the United States is significant and serious in that we have community spread in areas where many of these individuals are without symptoms. That is complicating our task.
Thank you so much, everyone, for such an engaging discussion. I'd like to thank you all for presenting and for connecting at such a busy and critical time. We'd also like to thank our sponsors for the support for the COVID-19 conference. Now, before the next plenary session, which will focus on the impact of COVID-19 beyond health, we encourage you to visit the conference program to view the amazing set of on-demand abstract sessions that are available. We wish you a nice morning, afternoon, or evening, depending on where you connected with us for this session. Goodbye.